Hello, my name is Dr. Joseph Mikhael. I'm a professor at the Translational Genomics Research Institute and the Chief Medical Officer of the International Myeloma Foundation. It's a privilege to talk at year's end a little bit about optimizing the current management of multiple myeloma. This is a disease that has just changed so much over the last few years. It's mind-boggling trying to keep up with all of the things that are happening, but we're going to hit some highlights of really what has been practice changing over this last year. And perhaps the first of them that is particularly relevant has been the determination trial. So this was presented, in fact, as plenary at ASCO. I had the privilege of being the discussant of this same abstract, and it was presented by Dr. Paul Richardson. The short version is this was the American version, if you will, of the IFM study that had looked at the role of transplant in modern therapy. So patients were randomized to either receive RVD or lenalidomide, bortezomib, and dexamethasone, or lenalidomide, bortezomib, and dexamethasone plus a transplant, as you see here in the figure. And then all patients actually were given lenalidomide maintenance until progression, which was a little different than the IFM study where they gave it for a short period of time. What was the bottom line from the study? A major improvement in progression-free survival if you had had the stem cell transplant, improvement of over 20 months in PFS. So at first this looks unequivocally clear that everyone's going to be using a transplant. However, interestingly, albeit a secondary endpoint, there was really no difference in overall survival. And unlike the French study, we didn't see quite as many patients cross over to get a transplant at first relapse, only about 28% of them versus almost 80% of them in the French study. So what's my take on this? Well, on the one hand, we could say the sheer magnitude of the PFS says we really want to do stem cell transplants. That should remain the standard of care. We do know also that that prolonged maintenance seems to make a difference, but it didn't let those people that didn't have the transplant catch up. We're in a modern day of thinking in myeloma. We don't save the best for last. Let's use our best up front. So let's be aggressive up front. And it builds on other studies that continue to demonstrate the benefit of transplant. And lastly, if we don't do transplant up front, we may lose the chance. However, the corollary arguments or the opposite arguments are saying, well, overall survival wasn't improved. And we know that this was actually only in patients 65 years and younger. And everyone seems to apply this to patients 65 to 75, where we know the toxicity is higher. And there is a cost to toxicity, both short term and long term, including second primary malignancy. So the bottom line here really is that there's still debate in the area. I think that it remains an option. In my estimation, it's not fixed at front line. We can potentially use it later in patients who have a good response initially. And I do think in the future, we won't always be going to stem cell transplant.
We could spend a whole hour talking about this, and we will in the webinar, but just a couple of things preliminarily. We see the data, but do you think that most investigators, including yourself, really do believe that there's a survival benefit? And if you really think there's no survival benefit, why would you want to do it?
That's a great point. I think we typically, I personally don't think that by itself it is going to provide a survival benefit in everybody. If we're going to see it as more likely going to be in the high risk patient, those patients that really need that more intense therapy. And that's a reflection of the fact, Neil, that we have so many great salvage options later. You know, we've learned even in transplant ineligible patients, they can go 5 years on a first regimen. So I do think that this is a step towards transplant, frankly, leaving us and not being standard of care across the board. But there are some patients in whom our more novel treatments aren't as effective, and in particular the highest risk patients that need that extra boost, where I think in those people it still may remain a standard.
Another just sort of quick question. One of the things that was observed there that you commented on in your discussion was the lack of benefit in African American patients. Do you think that's for real or maybe just a numbers thing?
It may just be a numbers thing for now. I think we need more data to prove it, because most studies have demonstrated that African Americans actually have superior outcomes when given equal therapies to white Americans, although we're also seeing a little bit of that signal in CAR T that may not be as promising. So I think it's thought provoking. It wasn't powered enough to really answer that question, but I do think it is worth doing. And one thing I will commend the investigators of this study is that we did see a significant significant participation of African Americans in the study. And only when we see that are we going to be able to understand these signals better.
Yeah, that was really impressive. Okay, please continue.
We can't look at 2022 and not comment on the Griffin study, which was the study that has perhaps more than any other moved us towards quadruplets in frontline therapy. And this was a study that compared the standard of care now in many respects of VRD to now adding DVRD, so adding daratumumab to the bortezomib, lenalidomide, and dexamethasone platform. And this was a randomized phase 2 study, so it's not a phase 3. It will not be what moves this combination to approval, but nonetheless is very important. And what we saw, interestingly, in this study at each cut of it, and this was the most recent cut presented in the International Myeloma Society this year annual meeting, was that at each level after induction, after consolidation, which included, by the way, a transplant and 2 more cycles of either RVD or DVRD, after 1 year of maintenance and at the end of the study, in each case, the response deepened. So we are seeing the benefit of the 4 versus 3, if you will. So in addition to the deepening of response, we've now seen that response carry over into progression-free survival. And we're finally seeing these curves indeed separate, interestingly, not till almost 3 years, but we are seeing the benefit of this quadruplet over the triplet with daratumumab being added to VRD. Obviously, with more time, we'll see this, but with a hazard ratio of 0.45, this is a signal that we believe is real. So what's my take on this? Well, we really are already moving to quadruplet therapies, in particular in patients who are eligible for an autologous stem cell transplant. It's already listed on NCCN. The justification, of course, is that we see this continuing deepening. And even though transplant still has a role, we still see further deepening with using this thereafter. What's probably unclear yet from the Griffin study, its design allowed the daratumumab in that arm in the maintenance phase to be given for 2 years, then just lenalidomide alone. Not everybody is doing that, and we're still unclear as to the value of that daratumumab in maintenance therapy, but that's still to be determined. And also as a segue to other quadruplets that we're seeing now, where the carfilzomib is being switched out for the bortezomib, or isatuximab, another CD30 antibody, is being switched out for the daratumumab. On that vein, another very important quadruplet study, now not just so much seeing the value of the quadruplet, but starting to move us in a direction of, can we stop therapy? This is a kind of study that our patients are very keen to learn from, because as I always say, Neil, my favorite drug is nada. I want to give nothing whenever I can if I can stop treatment. And so the design of this study was to give what was felt to be the most intense quadruplet we have, daratumumab plus carfilzomib, lenalidomide, and dexamethasone, along with a transplant, and then continue that quadruplet until someone reaches MRD negativity, not just once, but twice, at least 3 months apart. And then at that point, the drugs could be stopped and patients would continue just on lenalidomide maintenance, as you see here. And the bottom line was that it did seem to be an effective strategy in patients that did not have high-risk cytogenetic abnormalities, or perhaps even patients that had one high-risk cytogenetic abnormality. But those higher-risk patients with 2 or more high-risk cytogenetic abnormalities defined below, as you can see, unfortunately, their outcomes were significantly inferior. And so my take on this really is an important first step moving us to stop therapy. And part of that is going to be using MRD, and not just MRD negativity, but this concept of MRD sure, of having it more than once, some kind of sustained MRD, although maybe 3 months is too little. It is interesting to see that the patients with 0 or 1 high-risk cytogenetic abnormality seem to perform very similarly. So maybe we're overcoming some feature of high-risk disease with this approach, but it still isn't the answer. And I think we all realize that although this was an important study to do to start to set the lines of what we can and can't do, it's not yet the full answer, especially in higher risk patients. We definitely need more for them. And MRD, sure, as it stands in this study, was not sufficient to stop treatment. The next study is the famous Maya study that we saw really presented in large form last year, but now has been updated further. And I think it's worthy of mentioning, Neil, because it really is incredibly influential in patients that are not going to an autologous stem cell transplant and has really become the new standard of care for nearly all patients. Giving daratumumab, lenalidomide, and dexamethasone continuously led to really impressive outcomes we've never seen before in almost any myeloma patient. So it really is impressive to see both the PFS and OS benefit that we saw with Maya last year. And now it's been updated further with really not a lot of change in the sense that we're still seeing with much longer term follow up that we still have over 50% of patients not progressed at the 5 year mark and 2/3 of them alive, comparison to 30% PFS in just RD and just over half of them alive at 5 years. So I think this is a critical study and really has become the standard of care in transplant in eligible patients. We're seeing a shift moving from the VRD strategy using bortezomib, lenalidomide, dexamethasone. It's less toxic. We're seeing better outcomes. We see less neuropathy. And these updated results are important because we're seeing not only the PFS and the OS benefit, we are seeing that they're literally quadrupling the MRD negativity. I think where there may still be a question, Neil, in our minds is what do you do with that really high risk patient? Do you still want to give them a proteasome inhibitor? And now we're doing studies of saying, well, can we give that full quad like we saw with the Griffin study to transplant ineligible patients by adding bortezomib, even if it's only for this first 6 or so months or maybe up to 12 months? And that's actually kind of what I'm doing in my highest risk patients is trying to give them low dose bortezomib starting weekly, maybe even every other week, because in the VRD study in SWOG, patients actually had an overall survival advantage just having had 6 months of bortezomib. So I think there is something about even a short course of proteasome inhibition in these patients that are not eligible for transplant. On the same subject of quadruplets, before we start looking at more relapse settings, we had the German study, a GMMG study of adding isatuximab to VRD. So in some ways similar to what we saw in the Griffin study, but here we have a quadruplet of ISA RVD being compared to RVD. And last year we had an update on what happened before transplant, and now we're seeing what comes later. What's interesting is this is the first phase 3 study in frontline myeloma where the primary endpoint wasn't just response rate, actually was MRD negativity. And it's remarkable with 18 weeks of treatment, even before they had a transplant, with isatuximab VRD, that 50% of people achieved MRD negativity, whereas it was only about 35% in those that had the RVD alone. And so this is really important, I think, because even though we talk about Griffin, it is only a phase 2 study. This is the first phase 3 study we've seen with quads, with MRD, as I've mentioned, as an endpoint, with obviously that depth of response even before someone gets to a transplant. Right now, there does seem to be no issue with collecting stem cells. This was a bit of a challenge in the Griffin study, that it was a little bit more difficult to collect stem cells in patients that had had a quad. Obviously, we need a bit more data to know this, and it will be more important to see the impact of that transplant after induction. But this is yet adding another brick to the wall of quadruplets, where more and more we're likely going to be using quadruplets across the board in the near future. Similarly, here from our friends in Germany, again, they have a ESAB KRD study, and now looking specifically at the highest risk patients. And so, as we understand myeloma more and more, this is not one disease. This has a tremendous spectrum between standard risk and high risk. And so, they wanted to explore this actually in patients both who are eligible and ineligible for transplant. Can we give them this arguably arguably most intense quadruplet that we have now. And so even as a concept, I think this is important because it's pushing the envelope a little bit, helping us see what we could potentially do. So obviously in those eligible for transplant, they were going to have one. And those who are not eligible for transplant were actually going to have ESA KRD for 12 cycles, followed just by ESA KR maintenance, where we drop the dexamethasone. And so my take on this study, obviously it's a little bit preliminary in getting a lot of results, but we all recognize that high risk disease remains an unmet need, if you will, in myeloma. There's some patients whose disease just takes off like a bonfire. And I think we will be using more quadruplets in this group. I think we all recognize that carfilzomib is more potent than bortezomib and is actually more sustainably given over a long period of time. Every drug goes through evolution, and now carfilzomib we're typically using once weekly, and that has made it more sustainable to give over time. And I think what's interesting about this study in particular is we really do see the feasibility of giving this intense a quadruplet, as long as we give it carefully, in patients that are ineligible for transplant. Ultimately, as a phase 2 study, we'll need a phase 3 for full proof. But again, it's stepping us in the direction of understanding quadruplets in particular in high risk disease. Another important proteasome inhibitor to include in our discussion was the update, or the final results actually, of the IFM 2013-06 study, which was just published this year, which looked at giving the triplet combination of ixazomib, lenalidomide, and dexamethasone in newly diagnosed multiple myeloma patients. This was meant to obviously see if we could supplant the, at the time, current standard of care with VRD by switching out the bortezomib with ixazomib, which is an oral drug and also has considerably less neuropathy. Interestingly and encouragingly, there was a 92% response rate, but the PFS was 41 months. And the 3-year overall survival was 92%. And although these numbers historically better than what we've had in the past, are definitely inferior to what we have seen with both VRD and indeed now with the quadruplets. So although it's an attractive combination, it was given in a small number of patients. It was also a little bit unusual that they had limited in the design of the study to give 1 year of ixazomib maintenance. And although the toxicities were very manageable, and there obviously was not the kind of neuropathy that we might see with VRD, we definitely saw it as an inferior outcome to VRD and even a DRD. And it's unfortunate because we've seen this history of ixazomib is really not performed in the way that we've perhaps wanted in frontline and maintenance therapy. But I do think it still has a role, Neil, in certain patients who really could not tolerate bortezomib, and patients who are older, more frail, and particularly in various combinations. We also saw this year, now moving to a more relapse setting, we saw updates in the Icaria trial, which was the study of isatuximab plus pomalidomide dex versus pomalidomide dex. This was the first indication for isatuximab. It was given in patients who had had 2 prior or more lines of therapy. And at our International Myeloma Society annual meeting, Paul Richardson updated the overall survival data of this study, demonstrating, as you can see here with considerable follow-up, that there was a persistent not only PFS benefit as we saw earlier on, but now an overall survival benefit of approximately 7 months. So you see here about 25 months versus 18 months in these patients. So I think it's good that even in later relapse, we're seeing an overall survival advantage. And I think 7 months is clinically significant. Thankfully, we also in the longer term didn't see any unusual safety signals. I think what this raises, though, is further questions a little bit about what do we do in sequencing CD38 antibodies. We know that we shouldn't use isatuximab immediately after daratumumab. I actually had the privilege of leading that study. We gave isatuximab to people who just failed daratumumab. It didn't overcome its resistance. So it's not like moving from, a first to a second generation immunomodulatory drug or proteasome inhibitor where we know it can overcome resistance. They're very similar. And so most of us now have agreed, until we have more data, that if you're going to retreat with DARA or go on to ESA in someone who's already had DARA or ESA, we should at least have a line of therapy without a CD38 antibody in between, to see if that CD38 antigen can be reinvigorated. But at this point, Icaria with isatuximab, pomalidomide, dexamethasone remains a very potent combination in relapsed myeloma. The subject of using isatuximab in relapsed myeloma, I had the privilege of providing the most recent update in IKEMA at the Leukemia Lymphoma Myeloma meeting in New York City in October, where we looked at now longer term follow up of the benefit of this combination and progression free survival when compared to carfilzomib and dexamethasone. And I think this was important to include in a year end evaluation, Neil, because this is the first relapse study in myeloma where we see 3-year progression-free survival in the intervention arm. Now, interestingly, carfilzomib dex by itself performed quite well at 19 months. Now, that's not something to ignore either. But adding this third drug of isatuximab, and I think it speaks to the synergy of these two drugs, but also of using them early in relapse. I'd commented earlier that we're moving towards a more intense treatment earlier in the disease course of myeloma. I always say, saving the best for last is great for a Hallmark movie, but not for myeloma, right? We want to use what we have earlier on. And so we're seeing more and more studies using carfilzomib at first relapse. We had previously seen the Candor study, and now we see this IKEMA study. And so this was driven by a deepening of response, no surprise. In particular, if we look at the MRD negativity, we're getting a third of these patients who already have relapsed myeloma. Half of them had had more than one prior line of therapy, and half of them had had one prior line of therapy. A third of them are getting to MRD negativity, whereas only 15% in those patients that are receiving carfilzomib and dex. So this is really an unprecedented progression-free survival. I think carfilzomib is a very attractive partner in early relapse, and this is one of the few studies that used carfilzomib indefinitely instead of just defining an endpoint of 12 or 18 months. And so we saw this impressive PFS driven by a deeper response. And although I didn't show the data, we even had improved PFS2, which of course is always an important concept to ensure that we're not, if you will, burning bridges for the future if we use an intense combination like this in early relapse. We had the final readout of Columba as well this year on the subject of using a CD38 antibody. This is not brand new news in using subcutaneous daratumumab, but I think is a reminder to us now that it's really penetrated more into community practice, that this has become really the new standard of care of giving fixed dose subcutaneous daratumumab versus IV. And so when they had looked at the overall response rate, giving it subcutaneously was clearly non-inferior. If anything, it was close to superior in doing so. And that when we looked at the max C trough, so right before that third cycle, we saw that we still had enough penetration of the drug into a patient's system, giving it subcutaneously versus IV. And as you can see here, this non-inferiority outcome was there, if not even it appears to be superior, but that was not the design of the study. And so we can feel very comfortable giving this drug in this way. And the updated analysis that we saw compared to that primary analysis of 41% is now 44%. Earlier with IV, 37%, now 40%. So very similar outcome. There wasn't any late-term signal that made us concerned, whether it was in the response rate or in that Cmax, as I mentioned. So my take here is this has been critical. I mean, what a massive difference for patients. Whereas patients before came in for hours, now we schedule them for less than half an hour because they come in, get their blood pressure checked, check in how they're doing, and they get a 5-minute literal infusion subcutaneously. It's really quite impressive that it's really shortened our times of keeping patients in the clinic. It's also had the added benefit of a dramatic reduction in infusional reactions from anywhere to 30 to 40%, depending on how they were being treated, now to less than 15%. And in fact, often even less than 10% in real life now. And so this is why we're seeing pretty much everybody moving from IV to subcutaneous daratumumab. On that subject of CD38s and subcutaneous use, I was happy to see that Hung Kwok from Australia presented just at ASH recently the updated analysis of using isatuximab subcutaneously. They have an interesting, as they call it, the OBDS, the on-body delivery system. So as opposed to a simple infusion, there's almost like a little pump that gets put on the arm or the abdomen and is pushed into the patient by it's an injector that has to be given by a healthcare professional. So it's not self-administered, but it's not as a drip infusion as we use in daratumumab. And in this study, they treated 56 patients and they tried different ways in which it was administered. And the bottom line is that they had very infrequent infusion reactions. The duration of that injection was about 10 minutes for most patients. It seemed to be tolerable well. There are a few patients, no surprise, that had some local skin reactions and injection site reactions, but nothing that was by any means defining or exclusionary. So we've been waiting for this. I mean, I think it's just so much more desirable to give a drug subcutaneously, even though isatuximab had a shorter infusion than daratumumab. After the first 2 doses, it only takes 75 minutes to infuse. Nonetheless, if you have a choice between 75 minutes and 10 minutes, I think I would take 10 minutes, and that's typically how we would look at it. And so, with similar efficacy to IV, I think we're going to be seeing this in the future. It's not quite ready for prime time, but we are getting close to using isatuximab subcutaneously.
Yeah, I was just going to ask how you would compare the data that you have for sub-Q ISA versus DARA, and any projections on when sub-Q ISA might be available.
Yeah, so I would see them again like I would see them intravenously, very similarly. Neil, I've had the privilege of developing isatuximab and working with DARA for years. I really don't see a major difference between them. And now with this early results of sub-Q, I think similarly, there isn't really a major difference in efficacy. There's some fine differences, of course, in frequency of it being given, and obviously cost sometimes, depending on someone's region, may influence them. How soon are we going to see sub-Q ISA? It's hard to get out my crystal ball, but my gut feeling is it's still going to take well over a year before it's going to be available in the clinic. But the latest I've heard is that maybe in early 2024.
Are there other trials that we're waiting on data from, or we're just waiting for the FDA to process this data?
There are other trials moving forward with this dosing. I do not believe it's been submitted yet to the FDA, but my understanding is that hopefully that'll happen in the near future so that we can use it soon thereafter.
Great. Please continue.
So another, I think, important article that was published this year that I think is valuable to us was published by Christina Gasparotto, was using once weekly selinexor with carfilzomib in dexamethasone. Selinexor has really gone through an evolution over this last year and 2 years. It used to be given twice weekly with dexamethasone alone, lots of challenges with nausea in particular, fatigue, and anorexia. But now, as we've used the drug at a lower dose in a once weekly setting, it's been much more tolerable and much more easily combined with other agents. And although the phase 3 trial was with bortezomib, it was very attractive to do this study in combining it with carfilzomib, because carfilzomib, as we noted earlier in the IKEMA study, is a very attractive target, a very attractive agent to use in early relapse. And so here, as you can see, the selinexor is given weekly, the carfilzomib is given weekly. They enrolled patients at different dose levels here, from as high as initially 100 milligrams of selinexor down to as low as 60 milligrams of selinexor. The phase 2 dose going forward, as you can see here, is with 80 milligrams milligrams of selinexor. And when we look at the response rates, obviously there's a lot of different data here, but really across the board, we see consistent response rates in these, generally speaking, heavily pretreated, although not having had carfilzomib before. And whether patients were triple class exposed or not, we saw a strong signal of response across the board. The duration of that response was also, in those who, of course, were responders, was just under 2 years at 22.7 months, with the median PFS being 15 months. So my take on this is this is critical to the evolution of selinexor, as we've mentioned, to now be paired with multiple agents, because we've not historically always wanted to use bortezomib in the early relapse setting. It's so much better tolerated now when we give it with two anti-nauseants, typically a 5-HT3 antagonist and a drug like olanzapine that can help with some of the anorexia feeling that patients get with it. This is actually my favorite combination to use selinexor with carfilzomib, in particular in patients with high-risk disease, just by virtue of the mechanism of p53 deletion, for example, or other high-risk abnormalities that we see respond well to both carfilzomib and selinexor independently, and now perhaps more so together. And seeing a 15-month PFS in this group of patients, I think is significant. Then, of course, this is reflective of the phase 3 study, as I indicated, of the Boston study, which did look at weekly selinexor starting at 100 milligrams with weekly bortezomib in the intervention arm, and the control arm being given twice weekly, where there was, of course, that roughly 4-month or 4.5-month improvement in progression-free survival of the triplet combination. There was an update this year in looking at patients that had renal impairment, because there were patients included in the study even with creatinine clearance of less than 40. And we did see a reduced PFS in these patients, but there was still the preserved benefit over VD alone. And so it's not a surprise that, unfortunately, patients with renal insufficiency, at least of that degree below 40, tend to have inferior outcomes. But we saw the feasibility of giving this triplet to them and how it was still better than the doublet. And thankfully, one of the other features we typically see with patients in renal impairment, not only do they have reduced efficacy, they have considerably more toxicity. We didn't see as much toxicity. And so the similarity of the AEs is encouraging, and this can be a preferred regimen in those patients.